lot of questions that I won't be able to.
So let me just explain a little bit about who I am and how this whole thing works or doesn't work. I'm Carleen Bensen. I was a practicing urologist in the community since 1992 and then decided to retire and felt like I really wanted to contribute still to the care of patients in the community. So I ran for hospital commission and got elected. It's my first experience as being an elected official, first experience of being on a governing board, and started my term in January. Uh, the Board of Commissioners is seven, there's seven of us. Three of us are new. Jerry Steffens just got elected the same time I did. And then after John Nutter passed away, we appointed Nancy Field. So there's three of the seven board members who are very new at this. And there's the learning curve is incredibly steep. Because we are public officials and we fall under the State Public Meetings Act. So if there are four or more commissioners at a meeting, it becomes a public meeting. So there seems to be a feeling that we want to avoid that at all costs. And so all the subcommittees, all the committees that are part of the board have three or fewer board members on the committee. And unfortunately, there's not a lot of communication between the committees. So, like finance, UW, the UW collaborative, quality,
Governance?
governance. I'm not on any of those committees, and so I can't answer a whole lot of questions that you might have about them because nobody shared this information with me. It's a very weird, siloed kind of thing, and it's driving me absolutely batshit crazy. And I've been really complaining a lot. So hopefully there's going to be a change in how things happen. Right now, if you look at the bylaws of the board, there's under committees. Every committee that meets before a board meeting has one of the public meetings should have a synopsis or the minutes of their meeting from their subcommittee in the board packet. That doesn't happen very often. I am the chairman of the Joint Conference Committee, which is physicians, the administrator, and board members to address physician issues. All three of my meetings minutes have, well, not minutes because they've reduced them to bullet points, but all three of my meetings were reported in the board packet. But that's not the case with most of the other committees. So I feel like, people ask me questions, people expect me to make decisions, and I'm kind of lost. So I'm working really hard to get more communication within the board, within the law, because if you have a meeting and you send the report of the meeting to the other board members, that's considered a serial meeting. And it has to be a public meeting because now you've added four or more people. So the way that the law is written is very difficult to run a board. But I think the culture of the board has also not been very much on communication and transparency. So working hard on that.
Yeah, the obvious question is why shouldn't all of those meetings be public as well?
Exactly, exactly. And that wouldn't be a bad thing either. I don't, what we talk about is just quite all right.
Yeah.
To have the public as part of it, but that's been the focus of the board is to avoid public meetings. We have the two a month, the first and third Wednesdays, but everything else we keep under wraps, so to speak.
It also seems like there's I lost my train of thought. It was so important.
Well, it's an important thing. The other thing is being on the board. There's and we were told we are governance, we are not management. Is that what you were thinking
No,
of?
I was actually thinking of the role of the chair.
Oh, okay.
It seems like there definitely is things you must defer to the chair for.
Yeah.
Correct?
Yeah.
Yeah.
So, but basically, the difference between governance and management has been a real hard sell for me. I don't quite understand. We have one employee, the board has one employee, the CEO of the hospital. And the administration are responsible for the management, and we're supposed to oversee his function. Been told to stay in my lane a number of times. But that's part of this, my learning curve of learning how to be a board member. So I apologize in advance if I can't answer your questions. It's because I'm not on that committee. So
But there's ways to find out
Oh, yeah.
and direct people to the right people, right?
yes.
Yeah. And
Can everyone hear?
Yes.
I can't hear Laurie very well.
Yeah.
Carleen projects better. Do you have a microphone there?
it's
Yeah.
right here. Is that better?
We have a room
Yeah.
Okay.
microphone we can use if we need to behind you, but I have to turn that on. Would you
Okay.
like to have a microphone to hold?
If you keep hearing me fade out, I'll go to a second microphone,
Okay.
but give me a chance.
And I think this is probably blocking your voice a little bit.
Yeah.
So again,
Yeah.
We're not open to questions yet.
No questions yet.
No questions, okay.
Well, this part I haven't really started. If it's things
Yeah.
for Carleen, go for it.
Yeah.
I just wanted to comment about the public hearing. It
Mhm.
seems that for transparency, that if you did have 4 people on the committee and it became a public meeting, I don't think that would be a bad thing in transparency's sake. You could always say, not open for public comment,
Right,
but they could still come and listen.
sure.
And that should meet the legal requirements, I would think.
And if there's something that should be protected information, could always go into executive session. So,
Yeah. Does everybody here understand the difference between governance and operations?
Oh, yeah.
Okay, so don't
Good
really need to go into that a lot.
yeah.
Okay. Okay,
So are we going right to the slideshow?
I think screen share now. Okay, so the OMC is still facing a lot of financial challenges. We had a $40 million operating loss in 2024, 13 million the following year, and this year the losses are anticipated to be $5 to $8 million, which was actually projected in the budget, as I recall.
Yes.
Cash on hand is 28 days cash on hand is 28 days as of April
26 in May.
and 26 in May. Okay.
Laurie, you have to tell me what slide. I was on the first slide, so.
Oh, okay. Second slide. Yes. Says financial challenges. You there with me now?
Yes.
Yeah.
Okay. And our accounts payable in April were 26 plus million dollars, and there were some overdue accounts, although that is being brought down a little.
I think it's pretty similar for May.
Okay. Our bond covenant requires 60 days of cash on hand, and the target for your best bond rates is 173 days. So our bonds really need to be refinanced, or they risk being called because we're not meeting the covenants.
Right.
It's a 4 to 6 month process, and they were just beginning it, I believe. And now the interim CFO, Mr. Stillman, has given notice and is leaving in July. So I'm not sure where that's at. Do you know more?
What I found out is that there are a couple of people in the finance department that know how to do this, that he's trained them for this bond thing.
Okay.
So there are people who will be able to carry that forward.
Okay, well, that's good. Okay, next slide. So can't forget the national influences on our financial challenges. The pressure is only increasing on rural hospitals. Federal changes to Medicaid and the ACA subsidies affect all hospitals. but even more they affect the rural hospitals. And we anticipate a reduction in the insured patient pool. This leads to more uncompensated care, which means more bad debt. And that's a big problem for little hospitals like ours. Half of rural hospitals are running in the red throughout the country, and a third of them are at risk of closure.
Laurie, I think the number is like 720 rural hospitals. That's what a third of the rural hospitals, 720 rural hospitals are at risk of closing.
And others are being snapped up by private equity.
Not as much.
There was a recent one in Virginia, I believe.
Yes,
Yeah.
but I think that private equity isn't doing so well right now. So I think that threat is not as bad as it was.
Okay. Next slide, please. There was a recent audit by Baker Tilly, and in their report, they said OMC has suffered recurring losses from operations, has failed their financial debt covenants, and has stated that substantial doubt exists about their ability to continue as a going concern. They also stated everything since the last audit is incrementally worse. But don't worry, folks, there is some light coming. It's time to look at operational challenges. Next slide. So we've had a huge amount of provider turnover. We've lost about a third of our providers, and that's 23 total providers at OMC. Providers feel they are not being heard. And that's where, when I finish going over this, I want you to talk about your governance committee. The walk-in clinic is short-staffed, and this is leading to more than 4-hour waits, with costly referrals to the emergency room for labs and imaging, which normally could be done in the walk-in clinic if they had the staff. I've even heard of providers who have worked solo with only an MA for support and not even a nurse for triage. So people were just stacked up out the door, and they were leaving without being seen, which is a lost revenue opportunity, as well as a delay of care for those patients and a loss of community goodwill. So
yes,
tell us about the governance committee.
Okay,
not governance.
The joint conference
Thank
committee.
you.
So that's when you start as a commissioner, the board president asks what committees you'd like to be on, and I said, oh yeah, joint conference, that sounds good. Having been a physician, I know all the docs in town, and this would be a good opportunity to work with the other physicians. And then I found out that this committee hasn't met for 10 years. Oh, well, that's kind of interesting. But when you look at this provider turnover, we look at the loss of the number of physicians and mid-level providers that we've had in the last few months. I said, we need to have a meeting. We need to find out, and we need to drill down on this. The other problem is that at the present time, Olympic medical physicians, which is the physician part of the hospital, the ones that are employed directly by the hospital, are part of Olympic medical physicians. Dr. Chen has not done anything lately, and he's now gone. So we don't have a physician, we don't have a manager, a head of this whole thing. So Mr. Gregson's been sort of doing that, but it hasn't been working out all that great. So I thought we need to get everybody in a room and talk about this. So I invited 4 physician leaders, Mr. Gregson and Phil Giantoli, the board president, and we've had 3 meetings now, and now Nancy's on the thing. So we talked about things, like provider satisfaction, provider, morale, contracts. That's been a big deal. We've been kind of dinking around, waiting for this Kaufman Hall assessment before finishing getting the provider contracts done. Usually those are done in January, and physicians have been working essentially without an updated contract since then. And they're very nervous because they don't know what's the new contract going to look like. Is it going to be, am I going to be making the same amount of money? A lot of the providers are the sole provider in their family, single moms or whatever, and they need to know if they're going to be making that same kind of money. And I've been hearing this stuff loud and clear. My in basket is blowing up with, all these former colleagues of mine telling me all this stuff that they're concerned about. So we've had a few meetings. We have a survey going out tomorrow to all the providers about what could we do to make things better. What are the three most important things that in your practice? Do you feel like you're being supported? What can we do to make things better? So we've got this survey going out so that people feel like they're being heard and then actually doing something about the answers for this. So that's been the biggest thing. I never realized how hard it was to get a group like that together. Like, what day, what time can you meet where everybody can be there? No, I have surgery that day, and that kind of stuff. So it's been a challenge, but we've been really working at that, talking about things like exit interviews. There hadn't been exit interviews. And that's key. That's a key management thing, not just in healthcare, but just across the board. So, getting an exit interview system set up. But a lot of the problem has been because there's been no leadership in Olympic medical physicians, and Mr. Gregson is not able to be everything to everybody, even though he says he's going to. So, but that's been the problem. And then this whole waiting for the Kaufman Hall assessment. And do you want me to talk about that a little bit now, or do you want to? You're getting into that, I think.
We will be getting into it. And then
okay.
Keep adding.
Yeah.
There's a lot.
This Kaufman Hall assessment basically Kaufman Hall is an entity that comes in and looks at the entire operation and then makes a report. And this was something that the University of Washington required before they do any kind of merger with us or any kind of association. They paid for half of the cost of Kaufman Hall, and we paid for the other half.
There's 200,000 each or something?
About 200,000 each. And there's a lot of information in Kaufman Hall.
Yeah.
And you'll be getting into that in a little bit. A little bit.
Yeah. And then if you have more to add, please do.
I will.
I know you got a longer version.
Yeah.
Yeah, and I guess another thing, I remember that Kaufman Hall, Mr. Gregson was saying he couldn't really put much support into that whole assessment till after we got through a bunch of other things. And so I didn't realize it not only affected the UW affiliation, but it also was affecting contracts.
Exactly.
That's a big deal.
Yeah, we've been waiting and waiting, and finally the data is back.
Oh, okay. So I think we are ready for the next slide. Pediatric provider shortages were discussed at a recent meeting. Several of the pediatric group came and talked to us, and I'm actually going to share a video clip if I can get it to run. But I want to first just give you some key points that I picked up from their comments. One is that the provider shortages, at this point, they're pretty making the whole department unsustainable. They've lost 2 full-time positions out of 10.
One physician, one
physician and a nurse practitioner. Providers split their time between clinic and call. And they do ER consults or operating room consults. They do complicated deliveries and newborn resuscitation. When there's a problem, they will spend hours in critical care. And all of that means that they're very busy outside of the clinic, and not being fully staffed is a big issue. They also don't make any money for the hospital in those roles, because most of our new babies at OMC are on Medicaid. So I talked about the vacancies, and the other key point that I took away was that their last vacancy took 3 years to fill. And this time those positions haven't even been approved to be filled and nothing is posted. And so they're getting really anxious.
But that's changing.
Oh, good. Tell us how it's changed.
Yeah, well, Gregson says they're posting for these positions now.
Okay.
It's kind of interesting. Pediatrics is always traditionally a very low paid specialty. Pediatricians don't make a lot of money. And because a lot of their patients are indeed Medicaid, so they're not getting reimbursed well. The way that our pediatrician, and the other problem is now with pediatrics, is that a lot of the people going through pediatric residency are not interested in doing this neonatal resuscitation and the really hardcore, difficult stuff. They want us to see patients in the office Monday through Friday. And, so these people are coming out of residency to try and get somebody. One of the reasons we can't fill is because
there aren't any.
Yeah, there aren't any. And we're looking for people who've got the soup to nuts background or interest. And unfortunately, there's the newer graduates coming out are not interested in that kind of lifestyle. And what our pediatricians do, they see patients in the office 2 10-hour days. Then they're on call one day for 24 hours. But while they're on call, they're embedded in the walk-in clinic. So that way they're right there by the hospital. So if they have to run in for a delivery or something, they're right there, and they don't have a schedule of patients that they have to eliminate. They just, see whatever pediatrics comes through the walk-in. So so they're able to generate some revenue when they're on call. But a lot of times, if you're sitting around waiting for a delivery, you might be there for 8 hours and not generating any revenue. How do you pay somebody to do that? That's a big problem, and that's not just our hospital. It's
No, that's
everywhere.
a rural problem.
Yeah, that's a
because
big problem.
You have to have that baseline of services,
Mhm.
or you're not meeting the needs of the community.
Right. So
Yeah.
so it's a challenge. I mean, just the way that pediatrics is. And I'm trying to figure out how other rural communities are handling this situation. So that will be what I can do when I go to this Chelan conference, is ask other commissioners how they're handling their pediatric issues.
Yes. I think so. If we're going to run the link, this would be a good time. Are you able to get it to go?
See. I can't tell. Is that showing screen share? Let's see.
Well, we've covered it pretty well.
Yeah.
If
Yeah.
we can't run them, it's not the end of the earth.
Maybe this way.
How fragile babies are, you think they pay pediatricians a little bit more?
You think, but
And teachers and
right.
Yeah, the foundation. that we need,
yes,
Yeah,
absolutely.
exactly. But yeah, unfortunately,
right? A lot of
It
work
is
has
not
to be
screen
Well,
sharing.
is they don't have procedures. If you're a proceduralist, if you're doing colonoscopies, surgeries, cystoscopies, that stuff, you get more reimbursement. If all you do is see people in the office and you're not doing procedures, so family medicine,
They view it as less intensive.
yes. So family medicine and pediatrics are kind of at
It's
the bottom of the line.
the surgeon the payment system was set up with the surgeons as top dogs.
Of course.
And their stuff was more important and it got paid better. Now in some ways I can kind of see it. Yeah.
Yeah. But you're right. I mean, to be able to resuscitate a newborn is an incredible skill, and very important. And those, like you say, babies are fragile. Lots of them are.
The screen sharing it's opening to a 2-hour meeting.
It should open right to the spot I want.
It does not.
Hmm.
And It's
Just cut it.
2 hours and 16 minutes.
Well, it's not a clip, but it should start not at the beginning, but in the middle, and that's the
They get
beginning.
the Pledge of Allegiance.
Okay,
Good. Oh,
no,
boy.
then just let's skip it.
Yeah.
We'll
The
continue.
link is on here, and we will share these so people can go at home afterward and click on these links.
Yeah, the pediatrics testimony to the board was on June 3rd, and it's from 6 minutes 20 seconds to 16 minutes 27 seconds. So,
Okay, now I gotta make sure I'm back on the right screen share.
So Laurie, while you're waiting for that,
You have to speak up so that,
all right, while you're waiting for that, I just want to say this discussion around pediatrics is absolutely a poster child of the problem with our healthcare system.
Yes.
it
Oh.
is.
My husband started the children's clinic and it was a private practice. And they took care of themselves in the 30 years that he practiced. They never turned a child away for lack of payment. And they all made a reasonable living
Mhm.
and they were all on call and it worked. But now we have this big conglomerate and everything has to pay and earn itself and it's a mess. So I think it's just a poster child of what's wrong with the whole darn system.
Yeah, absolutely.
And like you were saying, you know, the graduates getting out of the, you know, universities that they're at, they're not showing the interest, right? A
Yeah.
lot of it is because of what people are being trained to believe, right? Or think that is valuable in life, right?
Yeah.
You know, you have to think of it as a family system.
Yeah.
You have to help one another. People, they just want something for nothing, right?
And they're graduating with $500,000 in debt.
Right.
They have to make.
Right.
Yeah.
No.
And you know, let's face it, medicine has always had issues with work-life balance. And, you know, the pendulum is now swinging more toward a better
Life
balance.
instead of
Yeah.
work.
And, you know, and it's not just in pediatrics, it's in a lot of specialties. You know, people just don't want to put the hours in that us old folks did.
Well, and people have different personalities just in medicine, just like they do everywhere else. And when I got my nurse practitioner education and certification back in rural Colorado, it was a distance program that I got to work with other nurse practitioner students. And because of what I need to stay calm, I knew I needed something focused. Another friend of mine, she ended up going into travel nursing as a nurse practitioner and was basically a locums in primary care and urgent care and even the ER. And her skill set just enormous. And that's the kind of person we need in the rural area. So not only do we have not very many of those, but a lot of them end up being still attracted to other regions. It's really hard to find replacements for rural providers. Are
and
you?
I'm trying to get this screen share.
But one of the things that I think that they will be talking about, the pediatricians, is they attend 30% of the deliveries.
Yes.
And in the last calendar year, they shipped out 45 kids. You know, not just infants, but 45 pediatric kids, in which case they had to be with those kids, like bronchiolitis or some, you know, difficulty breathing. We don't have a pediatric ventilator, so they may be ventilating these kids. And there's only one chopper that is able to ventilate a child. And if that chopper is picking up a kid in Walla Walla, we may be sitting here with a baby that can't breathe for 8 hours until that chopper can get out here to take the kid to Children's Hospital. So it's, you know, there's a lot of time involved, but that's the numbers. They have 30% of the deliveries, 45 kids shipped out last year. So that's, you know, it's not 100%, you know.
Mm-hmm.
There is some downtime, but when you know, it's kind of when you need them, you need them. It's not optional.
Right.
So we go to the next slide.
Yes, it's slide number 7. Okay. So orthopedics is another area where they came to report to the board, and they are critically understaffed, which is affecting patient access. In 2025, they had 8 surgeons and 7 PAs. They now have 4 surgeons and 4 PAs. Dr. Gouge and his PA have no appointments available till mid-August and September, respectively. Their schedule is 120% of full every day. And they have they're seeing roughly 30 patients per day, all the providers in that department. There's no scheduler to fill last minute openings from the wait list, and that assignment has fallen to the clinic manager, which is a sad waste of resources. There are fewer surgeons, so fewer surgeries, which means delayed care and declining revenue. It's a really big deal. It is. And it looks better on paper than it actually is, because all of it's hitting hard right now.
We do have a locums orthopedic surgeon who started just recently. He's on a 6-month contract, and I've heard that he's really good. One of the nurse anesthetists told me he did a very complicated fracture reduction and said, wow, he's good. He knows what he's doing.
Good.
So
Good.
there is a light at the end of the tunnel. Part of the problem with the PAs leaving is a lot of people went to Port Townsend where they can make more money.
That reminds me, I had a call from a 91-year-old lady today who wanted to know who to reach out to and to tell her story, which was that when she moved here a few years ago, she got so sick that she ended up in the hospital and almost died. And since then, she's had 5 doctors, and they're all gone now, and most of them to Jefferson.
Yeah, it's been a big problem.
Yeah. I think let's go ahead and take questions.
Yeah.
Well,
Walt is first.
I want to give you a patient example of what this translates to.
Yeah.
I have carpal tunnel in this hand,
Mhm.
bad enough that my hand is ringing.
Mm-hmm.
I have to go to see the doctor in Silverdale. They want me to come down there for a 20-minute appointment, get to know each other,
Mhm.
redo the test probably,
Mm-hmm.
and then they'll schedule the surgery.
Mm-hmm.
Just in cost of gasoline alone.
Oh, yeah.
Mention my time, which if I told you what I bill, you wouldn't like it.
Yeah.
That's a huge, enormous
Oh.
burden on the patient.
Absolutely.
And she's on dialysis.
Mm-hmm.
They won't even see her.
Mm.
OMC refuses to admit her. They just pile her into an ambulance and send her to any hospital that has room for her.
Yeah. Well, I don't think we don't have inpatient dialysis though.
Correct.
No, but you do have 4 blocks away,
Right.
one of the finest nonprofit dialysis centers, which does both hemo and PD,
Mm-hmm.
and they don't talk to you.
Hmm.
They would like to talk to you, but nobody from the hospital wants to talk to them.
Hmm.
They even have a physician who comes over here from Seattle, who I happened to talk to today and was talking about why don't people want to come out here? And she said, I don't know. I'd love it out here.
Mm-hmm.
If I had enough patients, I'd stay out here.
Yeah.
What are we doing, honestly, to attract surgeons, PAs? It's got to be better than we're going to pay you 125% of what you can make in Tacoma.
Mm-hmm.
It's got to be better than that. There's reasons to come out here. I know doctors and nurse practitioners who are here specifically because they like the environment.
Mm-hmm.
They like where they are. Now, most of them work for Jamestown.
Yeah.
Which seems to be running almost everything they do almost perfectly.
Yes. I
That's
agree.
probably why Jeff Tozer hates them.
Yeah.
Pause for a minute. Is this getting picked up, or do we need, if we're gonna do this, do we need a microphone?
I have to ask the people in the audience to please speak up.
What about a
because
microphone?
We have one microphone, but we have people online and they can often not hear.
Well, I'm pretty well done.
Yeah,
Okay.
yeah.
The point is, I'm never hearing, in all the years that I've lived here now, I haven't heard anybody tell me what you guys are trying to do to attract more physicians and more PAs and more nurses.
Well, I actually found out we do have a physician recruiter.
Really?
Yes. Yes, that's a surprise to me too. He was hired 9 months ago by Dr. Chen and Samantha Reynolds, and he's got a phenomenal history. This guy is really, he knows his stuff. His parents live in Squim, and he and his wife moved here to sort of like an early retirement kind of thing. So he's got interest in the community, and his experience. He's been a hospital administrator recruiter down in Southern California for some of the bigger systems. So and he's got a lot of energy. He seems to know what he's doing. I personally did a lot of recruiting for urology because we were always chronically short. It's a hard sell. It's very hard to get people to come here. There's no jobs for the spouse if they're not also in medicine. You can't eat the scenery, and housing prices are ridiculously high for this area. So people have, when you look at trying to afford a house here, it is difficult. But for a long time it was, well, there's no Nordstroms here, but you can shop online now. So that's not that big of a deal anymore. But it has been a challenge the 33 years that I've lived here to get other physicians. It's a tough place. And now that we don't have an airplane that goes to Seattle, I think that's a big issue. That's been a big issue. People are concerned about the schools. So there's a lot of things that are against us. We just have to get lucky and find the people who really want to live here.
And it does
Kim had a
happen.
question.
Yes.
I'm trying to read that second point, 8 surgeons, 7 physicians assistants in 2025, and then the arrow, and it says 4 surgeons, 4 PAs now. Am I reading this right? That's like these professionals, the people that actually care for us, have been cut in half?
Well, they
in 1 year?
left.
They left.
They did not get fired.
No, nobody got fired. It was voluntarily leaving.
But a lot of it's for the reasons we've been talking about, the uncertainty, the not being heard, but being talked at.
So why are they not being heard, and why are they talked out? How do we deal with it?
Well, that is already in the works. This is my opinion. My opinion is you can lay a lot of this on the interim CEO that was hired by the earlier board. And I watched the interviews. I sat next to people who watched the interviews, and he was the only one I would never choose in a million years.
Exactly.
Because he didn't listen even to the questions coming from the board members. He was appalling, and that his behavior has not changed from that day forward.
Yeah, it's difficult to have a conversation with him. He spins everything as everything's great, everything's wonderful, and no, it really isn't. But and individual practitioners who have met with him, he doesn't seem to. You're right. He talks over people a lot. But he's getting better. We're holding his feet to the fire a little more on that.
That's good.
So
And yeah, I've seen evidence of that in the board meetings.
Yeah.
Just saying, this is what we expect from you regarding recruiting pediatrics and all the rest of it. but also, aren't we in the works now looking for a permanent
Yes.
CEO?
Yes, we are in the process of hiring a permanent CEO.
Okay.
I'm sorry, I actually had a follow-up
Yeah,
question.
go ahead.
It seems to me this is a national problem. I mean, I did some Googling before I came to this and read some of the same websites, that talked about rural health and
Yes.
how many rural hospitals are in trouble.
Yeah.
It seems to me there ought to be some research done about other countries like Canada, like the UK, or Europe. How do they do it? How do they keep their rural hospitals going? Are they in the same trouble that we're in?
Yeah, that's the large part of it.
Medicare
Yeah.
for all.
Yeah.
But also a bigger focus on primary care, because right now, this is way beyond OMC, but right now our system, it's passing the buck from cost to providers and hospitals, gets moved to insurers, gets moved to patients. I'm leaving one out, aren't I? But anyway, it just keeps going like this. But the how much we're spending just keeps getting bigger, and that is not sustainable. And we really need a much bigger focus on primary care. In Costa Rica, they really partner their Medicare for all. That's just easy way to call it, with public health, and everything is paired up. And so in a relatively low income country, not the lowest, they have overall better access and better outcomes than we do.
Wow.
Almost every category.
Yes.
This is the
Yes.
value system.
Yeah.
We're number one in mortality.
Yeah. Yeah.
Okay, let's move on. We finished orthopedics, number 8. So let's talk about nurses. Nurses also feel their concerns are not being addressed. The first group that to come forward was to talk about what life is like working now at OMC was the cancer center nurses. And that was a few months ago. And I just want to give them kudos because that took bravery. Nobody knows if they're safe to speak up. And they talked about staff shortages in the cancer center that are impacting both morale and care delivery. Also, there is no remaining nurse leadership that it was originally part of the hospital. I think it's really been decimated. Everybody that's left is well, the CNO is another interim.
Yes.
Yeah.
And then she's got the OR director, OB. There's all the next level are all people that she's brought in.
Yeah. And there's a real disconnect for the staff nurses in terms of feeling like their issues are recognized and dealt with. Advance. So one of the issues that was brought up to me was artificially low census estimates are driving staffing on the nursing units. There was been talk for months about right sizing, right staffing, and staffing to the average daily census. That maybe could work, except that they're not accounting for patients who are on observation status, which means they're not a true admission. They're not acute care. And it's also not accounting for extended outpatient status. That's I think patients who are waiting for a bed, maybe from emergency room. Isn't that what extended outpatient would mean?
I'm not sure what that is.
I'm not 100% sure about that category, but what it does, if you're not counting those, then you're only counting the acute care patients, and you're staffing for those and leaving out all those other patients that still need care. So they've repeatedly brought this to management, but they've not had any response or any change. So that's what's going on with nurses. Anything that you are aware of?
Well, and then we've been slammed lately. The hospital has been, oh, the census has been very high. And now, they don't have enough nurses scheduled. So they're offering time and a half, double time, salaries. This isn't saving us any money.
Yeah, yeah.
I mean, I am so glad I don't have to schedule nursing because that has to be the hardest job on the planet Earth. Because you don't know what your volume is going to be from one day to the next. And, you get slammed with a whole bunch of people. We had no idea why the census went up.
I remember when I was in nursing in the hospital that when nurses got callbacks that they didn't want, they knew who it was from.
Yeah.
And they just didn't answer their phone.
Right.
I mean, a lot people are burned out when they're treated like widgets.
Yeah.
Yeah.
So this has been a real challenge lately.
Do historical trends help at all?
No, it hasn't really.
I remember talking to some excellent ER nurses who went over to Jefferson a long time ago, and they were saying over there they actually they know that they're scheduled for the day to not for the average daily census, but for what they can for unanticipated things. But if there's no work, they take turns going home, and it's just you will do that. And I think that sounds a lot more reasonable than trying to find someone to fill the gap.
Yeah.
Which leaves nurses with no lunch breaks, no pee breaks.
Yeah.
And trying to keep patients safe on a shoestring.
Yeah. They've been doing something like that, the daily huddle, and they look at the census and project, however you can as to what it's going to be. And they do send people home if they don't need everybody. But lately it's just this bizarre, this incredible, we had, the hospital's 73 beds, and we had like 80 people in the hospital because it was so busy. And that's just weird. I mean, it's not flu season, it's not COVID, it's not, people falling off cliffs in the park or anything. I mean, it's just been very odd. And so I don't know how you can staff that. And I really don't, you have no idea what's coming down the pike. But it's awful to see these, all these nurses are being offered phenomenal time and a half, double time. That costs a lot of money.
It does. Yeah. Next
Do you guys
slide.
have any nursing opening? Are there jobs posted for nurses? There.
Okay.
Absolutely.
Next slide. Number 10. Okay. So there's some quality and safety issues, although compared to last year, they're a lot better.
Oh, yes.
We did have a Department of Health survey. OMC had a Department of, I call it we because I feel like I have part ownership in this hospital. And so do you. The survey was at the end of May. They had one finding of immediate jeopardy. And that means that if you don't fix it now, they close you down. But a plan was presented to fix it, and that was accepted. And so there may be more action plans coming back from the Department of Health, but the immediate jeopardy part is resolved.
It was resolved within 24 hours, as it had to be.
Yes. It was a documentation issue. It had to do with suicide protocol and not documenting properly, which no patient was harmed, but the risk was there, especially if it didn't reflect, if it was reflecting what actually happened. I'm guessing it's probably a timed thing where you have to document every 10 or 15 minutes, and if you don't get it, then you're out of compliance, and your chart is what proves you did the work.
Yeah.
Documentation has been a persistent problem. That specific issue was one we had repeatedly last fall.
Yes.
Was it fall or whenever it was? No, it's more like summer or
Yeah.
spring. Yeah,
Of
whenever that
epic
was.
Proportion.
Sorry.
I said of epic proportion.
Yes. I've been pondering this for a long time. What could be causing it? And Epic might be part of the issue. It's certainly something I've asked nurses what they think.
Explain it.
So Epic is the electronic medical record that we all documented in, and if you have my chart, that's part of Epic. The Epic version that OMC has is hand-me-down from Providence. It
was
is
cheap.
Sorry?
It was cheap.
Yeah. And more to the point, if you get your own, the freestanding one, it's expensive.
Yes.
And I mean expensive. And it's not a one-time cost. It's more like a lease, isn't it?
Mm-hmm.
And what that means is that whenever Providence changes the documentation, it flows through to us, often without even notice, I believe. It may be noticed, but it doesn't necessarily fit our workflow, and it can be a real problem getting it fixed for ourselves. And I think that happens a lot.
Yeah.
So what we're doing is we're having to keep people re-looking at the paperwork to make sure that people are keeping up and doing it the way they have to, when it doesn't even match the workflow. That takes more nursing time, and it takes and it causes a lot of dissatisfaction because us time nurses want to be with their patients, not on the computer. That's just one possible cause or part of it. And it seems to me what's really needed is a root cause analysis, and it needs to include all the stakeholders, the nurses who are doing the care and doing the documenting. And I know some of it's not even nurses, it's other allied staff and probably providers as well.
Mm-hmm.
They all need to be in on it and saying, this is a barrier, and just do a brainstorming and figure out what's really happening. I think for too long at OMC, like in many hospitals, all the decision making happens from the top down. Any more comments on that?
Well, a friend of mine who's an RN who is on medical leave for an injury has actually been doing a lot of that root cause analysis. They hired her on to assess, where are the problems, and she's uncovered some pretty interesting things. For example, I think it was in OB. There are vital signs need to be, tracked, right? Pulse, blood pressure, temperature, and everything, and respirations. Well, the way that it's set up, the pulse and everything else is automatically populated into Epic, but respirations are not. That's something the nurse has to sit there and count the number of respirations per minute and then add that in separately. And that's one of the things we fell down on, was not having the respirations done. So she looked into it, she goes, well, in the ICU, patients have a strap around their
and they can count respirations.
And the respirations are already automatically counted. Why can't we use something like that in obstetrics? So there, we are working on that kind of stuff, but it's those little picky things that are just driving everybody nuts.
Yeah, yeah.
But something that simple, something that I think we can all understand. Yeah.
Here's an out of the box idea for you. The woman who started Epic is getting to retire. She was always private. She's worth $8.9 billion. She has a foundation, and they only give to 3 states: Wisconsin, Washington, and Oregon. So I suggest you apply and have an updated, top of the line Epic as a donation to Washington State, since we're part of.
That would be awesome. Yes.
Take away all but 1% of her $8.9 billion.
That would be good. She
So-
needs to.
Great CEO too.
Well, I've done some of the legwork because
So I think OMC
Yeah.
should apply.
Yeah. Good idea.
Epic
That-
donated to you.
that's a phenomenal idea. I already sent a snail mail letter to her as a resident here and said, this is part of our trouble. And would you consider instead of just donating after the fact, reducing the cost to rural hospitals or small hospitals
Yeah.
so that we can afford it?
Their children live in Seattle, so they have a big town to Washington. And her husband actually practiced in Port Angeles for a year.
Oh,
Wow.
So they have a leg up.
Oh, so I do think I've
Yeah.
in the water.
That'd be good.
Continue.
Chum the water.
Onward.
Yeah.
Sounds good.
We're half an hour is what we have left. so
Okay, well, I think we're getting,
We haven't gotten to
we're
the
getting,
meeting.
yeah. So that one's done. We're on
Yeah.
to 11. So the national picture is one of rural vacancies being very, very hard to fill. And beyond that, we have new uncertainty related to federal policy that affects the ability to hire healthcare professionals, especially from out of the country. In fact, we're in we used to draw from Canada, and now Canada draws from us. In September of last year, there was an executive proclamation increasing the H-1B fees for H-1B visa fees to $100,000 with no exemptions for providers and healthcare workers. That got a lot of resistance that was from both sides of the aisle. And I think they've,
Down by a judge.
sorry,
It was struck
Yeah.
down 2 or 3 weeks ago.
2 weeks ago. Okay, I didn't see that. That's great news. Okay. And there's also a bipartisan bill that may not, it sounds like it's not even necessary as long as we can trust that it goes up the chain and stays struck down. Yeah, we
Okay.
always have to watch. But beyond that, immigration policies are discouraging qualified workers from coming to the United States, period.
Mhm.
And we have a current and growing deficit of physicians and allied health and workers and nurses. A quarter of rural healthcare workers typically are foreign born and foreign trained. And what would we do without them?
Right.
So,
Don't you feel even just slightly bit guilty about poaching people from other countries?
well, I didn't used to. So how about a way forward? We're on to number 12, slide 12. So what's happening? We're going to have a discussion about what's happening with the UW affiliation.
Yeah.
The Kaufman Hall report was a requirement, and it has been completed. It shows $30 million in operation performance improvements opportunities. So that means we could save 30 million if we put all of the recommendations into effect. Also another 30 million, 50 million, I can't read my own writing. 50 million in savings from sale and lease back of 4 of our properties. That does not include the hospital. UW response was favorable. Mr. Giantoli told us at the last meeting that negotiations are proceeding, and the current timeline to complete those negotiations is the end of August. Their executive summary was really interesting. That's what was presented at the board meeting, and it's just the high level overview. And what I took away from that is that they recommend a much more robust financial reporting so we can understand the physician enterprise subsidy. It's the financial gap in health that health systems and hospitals cover to sustain employed or affiliated provider groups. I had to look it up.
I know, they use a lot of big words.
Yeah, they did. So basically, physicians and providers that are working in groups for the hospital, they don't cover all their own costs in general.
Right.
And like pediatrics, that's a perfect case example. And so it's what the hospital has to pay to cover that so that we can keep running and have the folks we need. This is information the commissioners have been asking for ages, and we just haven't had the knowledge in the hospital in that department, or I think the software to do it. Hopefully that is going to change. They also said that 30% of scheduled visits are not being utilized. So to me, I think that means sudden people that were on these schedules and dropped need to be filled from a wait list.
That's only part of it. They're just not scheduling very
They're
well.
just not scheduling well.
I mean,
But we heard in every example that came before the board that they don't even have the people to do the scheduling that they need.
Yeah.
And I'm sure there's software that would help with that too.
yes,
Yeah. They also said that 48% of patients who are not coming to OMC are leaving because of access limitations, those long wait lists, operational constraints, and gaps in the specialties they need. Some of that I could see UW picking up. Some of it, well, a lot more need. That's the high level, and the devil is in the details, I think. And that matches up what providers have been telling us. So, did you want to comment?
you had a
more?
question.
I have a question. Is UW's negotiations, are they reliant on OMC following Kaufman Hall's recommendations?
Great question. And because I'm not on that committee, I don't know.
Okay.
But yeah, I mean, I know that Kaufman Hall made a number of recommendations, and I don't know whether UW expects 100% compliance with that or not. There's certainly some, it points out some very, very good ways to improve revenue with better access and so forth. But, as far as that 48% outmigration, that's pretty sobering.
Yeah.
But a lot of it is we don't offer a cath lab. We don't have robotic surgery. There's a lot of stuff that we shouldn't be offering. That's not something we can, that we don't have enough N numbers to adequately staff a cath lab or to provide robotic surgery, because we just don't have enough bad cancers that would be treated robotically. So there's a lot of stuff that goes out, but there's also stuff going out because patients can't get in a timely fashion.
Yeah.
And
that's the fraction we've got to focus
right.
on.
And then there's specialties that we should be able to, like the orthopedics, if we're fully staffed, then we can do this.
Yeah. But did you see any low-hanging fruit when you dove deeper into the report?
Not really, I mean, it was just, there was a lot there.
Yeah. Yeah.
I think the low-hanging fruit was,
how many pages?
oh my God, yeah, it was like 150. Yeah, it was a lot, but a full report. But just the scheduling piece, I think, was the one that really struck me.
The lowest hanging fruit. Yeah.
Struck me.
Yes.
Laurie, so I read the article, and it did refer in the Kaufman report about the decrease in the scheduling in the clinics and whatnot. If it's 30%, that's a direct correlation with a third of the doctors leaving. I mean, like, do the math. It's like no doctors, you can't schedule that additional 30%.
Amen.
So this could work if they could bring in enough physicians to make it work.
Well, except that the Kaufman Hall data was from 2025.
Oh, okay, but before this.
Before we lost.
So we don't want to know what that number would be today.
I don't think you can use those numbers. I don't think that's an equivalent thing. But the Kaufman Hall data was from January 1st, 25 to December 31st, 25. And these, some of those positions that have left during that time, but most of them are after that.
And one other question is UW the prospect for selling our properties for lease back?
I don't think so.
Okay.
I don't think so.
But it's hard to tell because we don't know what the negotiations
We
are.
don't-
Yeah, and it's
Do we
it's
know
very
what
early
the
days.
properties are? Is
Um,
that Swim?
I believe so. It's, I know the medical office building is one of those, the one that's here.
Okay, we have
Yeah.
what, 20 minutes left?
Yeah.
Yeah,
Okay, let's save the questions now till the end. We're almost there and I don't want to miss out on anything. So slide number 13.
This is important.
This is really important. This is about critical access status. I know just a lot of people have a bad feeling about it, and it really hasn't gotten good press. It is being looked at again by the commissioners. In fact, I think they're running a formal study comparing the benefits and costs of sticking with prospective pay, which is what we have now, versus going to critical access. It increases Medicare reimbursement to cost plus 1%, so 101%. And it limits inpatient beds to 25. And that's acute care inpatient beds. It also limits the length of stay for acute care to 96 hours. But that's not that there's things you can do to improve that. You can add 10 beds that are for psychiatric or rehab. You can add 10 beds that are overnight beds for outpatient surgery. You can add 10 beds for a freestanding birthing center for overnight beds. And so that can help people. We can help it. That's it's a really significant improvement over that 25 compared to what we have now. And in my opinion, a 25-bed hospital is way better than none. So I'm really glad that the commissioners are going forward and looking at it and evaluating it really thoughtfully. What do you want to add?
Well, it's definitely something we're looking at. I don't think there are certain people on the commission who are dead set against it and some who are in favor. But we need to really look at this because we do not get paid for what we do under the fee for service, Medicare, Medicaid stuff. We do not get paid what it costs to deliver the care. So the interim administration was really big on let's improve volume. But if you're not getting paid, how is volume going to work?
Exactly. How does getting paid 50 to 80% of the dollar
Yeah.
Improve just by seeing more?
Right.
Yeah.
So that's been my biggest concern. And I talked to Eric Lewis about this back in 2018. So, this is something that the hospital has been looking at for some time. But, and if you look, my perspective as a surgeon, so much of the surgery we do here is outpatient surgery.
Yes.
So that would, or this outpatient overnight stay kind of concept. So, it really is not going to impact a lot of the surgeries. I was talking to one of the new urologists. She says she has not had a single patient admitted to the hospital
and
other than other overnight stay.
Wow.
Any of the cases that she's done. So it is, so it's not going to, the problem is going to be the sick elderly patients that come in.
But
where are they going to go?
Anymore, most folks who come in for a hip or a knee replacement, they're home after an overnight stay.
Right.
And if we were able to convert to rehab, get those 10 rehab beds, that would help with that elderly, fragile population that needs longer.
Exactly.
What are your last 2 points? What is that? Requires a waiver of moratorium. Yeah.
So there's currently a moratorium on new critical access hospitals in the state of Washington. And that's by legislation. But you can get a waiver, and Anacortes, the hospital in Anacortes, which is part of Island Health, a public health hospital like ours, has got that waiver from Washington. The second point is there is a 35-mile limitation between hospitals or medical centers. And that's a federal thing for being able to apply for critical access status. The thing is, though, when you read more detail, they give waivers for that if it's secondary roads, you only need to be 15 miles apart. And what I thought, well, but we have highways all the way from here to Port Townsend, but I looked it up, and by their definition, if there's only one lane in each direction, that is a secondary road. So we should be able to get that waiver too. And I can you tell us more about this?
That's what I've heard, the same thing.
Yeah.
Of interest, one thing, talking about Port Townsend, because they are a rural critical access hospital, they have the 25 bed limit. You know what their average daily census is? 13. So they have excess capacity. So if we find one of the things, like a blow-off valve for us, if we do decide to go with critical access, is we could send some of our patients to Port Townsend instead of having to send them to Silverdale, Seattle, or whatever. So, they've got a lot of excess capacity there.
Do you have a sense of how many beds are occupied by folks we're not getting paid for at all that we can't discharge?
This has gone down significantly. A couple of years ago, we had a lot of people boarding in the hospital. One guy was here for a year. We couldn't get these people out. A lot of these are the not so nice elderly, demented, but they're kind of violent. None of the nursing homes would take them because they were their behavioral issues. And so we were stuck with them, but somehow that has turned around. There's very few people now that are more than a.
That's great news.
Yeah, it is great news because it was awful. Yes, sir.
I see that one of the key questions is Medicare reimbursement and the critical care 101%. For every Medicare patient who comes in, that's the kind of reimbursement you expect. How do you raise is this a decision that's made by the Center for Medicare Services?
It's a program
they alone to make that decision?
It is a program for rural hospitals and
It's
set
by
up
CMS,
through
right?
CMS, yeah.
So my follow-up question is there action that Congress could take? I mean, I'm thinking about Emily Randall. Could she introduce a bill to instruct the Center for Medicare Services to increase the Medicare reimbursement rate?
We could only,
Believe me, that kind of stuff has been going on for a long time. Right now, I'm not holding my breath. I'd rather work with whole Washington. But and even that is going to take time.
Current administration, I'm not hopeful that we can get anything to. I mean, look, they're $1 trillion of aid.
Yeah.
It's not interested in. They're not interested in rural hospitals.
Yeah. I got an article from Jerry to read that I haven't read yet about how the rural fund, that special rural fund, is actually making hospitals shrink in size. Well, and I don't know what that means. So, because all I've read is the headline. But
so Laurie, when you have requires a waiver of moratorium, does that involve participation from us to put pressure on getting?
No.
I don't know.
At least at this point, I don't think so. I think first we have to find out what the results of the study are. And they actually have an expert involved in that study.
Yes.
Who knows a lot about those ropes and thinks that that the hospital can pass both of those hurdles. So we'll see.
When is the resolution of that study expected?
I don't know. I really don't know.
Hopefully not long. I wouldn't expect not. It would be terribly long, but do you know who's on that committee?
I think Phil is.
Okay.
but there's got to be a
more.
couple others.
Yeah. Okay, so what can you do? This is the next couple. This is number 14. Okay. So please keep track. Attend meetings either in person or on Zoom. You can, the Zoom meetings, they were telling us at the last meeting, that people weren't able to get on, and it turns out you really have to go to each meeting. It's even reposted as a link in the agenda for that meeting, and click on it, because there's more than one, and it's not the same Zoom address for the different meetings. So you can't just reuse the same one over and over again, and that might be why you haven't been able to get in.
And I don't think they use Zoom, they use.
They don't.
Teams.
You're right,
They
it's
use Teams.
Sorry, I should have fixed that. But you can also catch a meeting that you miss on YouTube. There's a channel for the hospital, and those recordings are kept for 6 months. You should also monitor the website, because I don't think it's changing as much now as it did for a while, but I do pick up on changes periodically, and you can, to be more prepared for a meeting, you can always print out an agenda. I'm hoping I'm seeing progress, and noticed at the last meeting there were board packets for us to pick up at the meeting. I'd love to see that posted publicly at the same time as it's sent to the commissioners. And I know the commissioners have been putting pressure on lots of people, so I'm hoping they'll continue.
We would like to see that board packet a week in advance.
And how often, how
A day in advance, maybe?
that's pretty bad.
Yeah.
It makes it hard to make decisions.
It really
And you're
does.
making decisions off it.
Information in that board packet.
Yeah.
You're just like, dude, I can't read it. I can't read that and absorb it in a day.
Yeah.
But that's another one of the communication issues we're having.
But typically for the public, it doesn't show up for 2 weeks.
Yeah.
And so it's 2 weeks old by then.
Mhm.
Yeah, not a lot of help. So check the site of the Board of Commissioners portion for agendas, minutes, and packets. Learn about the issues facing our hospital. Oh, next slide.
Oh, just a minute,
Oh, she's gotta get back.
my screen share
Oh.
stopped.
There we are.
Oh, hi.
Something happened.
They look.
Maybe you'd rather see us anyway for the end.
Norma,
What?
Can you, here's my perception, please correct them if they're incorrect. When Gregson was first hired, I looked at all the numbers and he was gonna cost us $750,000 per year.
Yeah.
Right?
And now what we hear is he only works 3 days a week.
4.
Okay, but we get to pay his way home to Arizona, so he has no interest in staying here and being part of it.
Right.
And yet we hear all these people are leaving because they aren't heard, and you're admitting that he talks about people. So my question is, why not is he still here? Amen.
Well,
Here.
we've engaged
Whitkeefer.
Whitkeefer, the same company that they used to get Mr. Gregson.
It's fine. It really is fine, folks, because like I said, only one of the people that interviewed from Whitkeefer was terrible. 2 of them were superb. So we could have done fine with Whitkeefer. We do need a national search. We don't. Yeah.
But the other part of my question is, does he even have a list of board expectations he's supposed to meet? So each month he has to report to you if he's met your expectations and goals?
Not officially.
Yeah, there has to be no.
There
reason.
needs
Yeah.
to be an oversight where he has expectations, and when he loses 25% of your providers, he should answer for that. Absolutely.
Yeah.
Does the board have a compensation committee
Compensation for
for the CEO?
not specific.
Most boards do.
Okay.
And the compensation committee's job is to tell the chairman
Yeah.
or the CEO if you don't do
This, right.
this and this, you will be fired.
Yeah. And I don't
And you
think,
have to be religious about it.
yeah, I don't think we have anything like that. Or if we do, I'm not on that committee.
I think if you don't have something like that, you're remiss
Yeah.
in your fiduciary
Yeah.
duty.
There's a governance committee that may have something like that.
But as a board member, you should have a list of those expectations.
Yeah.
Ask them every month, did you meet this yet?
Yeah.
She's right.
So you guys are fulfilling bullet point number 2. Let the board know your thoughts and concerns. You can email or call the commissioners. Not all the commissioners have their phone numbers listed, but many of them do. You can email the commissioners individually or as a group by using the board administration email that's on the webpage. And for a while, I think those weren't always going through, and I don't know how that's working now. So you might want to put commissioners, please confirm receipt, because like the comments, when I have emailed the commissioners, I haven't had a personal response. I think if you're dealing one-on-one, you're going to get more response. And if you think, I personally would love to see scheduled coffee with the commissioner or opportunities to meet the commissioners, maybe in rotation, to have a back and forth. Today we were just trying to get everybody back up to speed. And I think there are several commissioners who are actually interested in that.
Oh, very much so.
Yeah. And here's one of them.
Wait a minute, everybody, because before we stop, we've had people patiently online and they have some hands raised. So go ahead and finish and we'll go get some questions here on Zoom.
Well, the next slide just says, thank you. Questions?
So I will stop the screen share and let me see. We'll go to Linda. Linda, can you unmute and ask your question, please?
Yes, hi. It's in the chat too. I'd like to know which commissioners are on which committees.
I believe you can actually find that listed on the Board of Commissioners page. I've seen it. And you just, if you haven't spent time with that page, there's a lot of information in there. But that's
Okay, thank
you. And someone else have a question on?
Oops.
No, that's okay. No, we're okay. I just want to unplug there. Was there someone else with a question online? Or there, let me look in the chat here. I'm sorry. There was which commissioners are on which committees and can we ask them questions? And then the next question is, I wonder if they would answer questions from the community.
That's, I think, what we're talking about.
Yeah.
Yeah.
Maybe that's
Sometimes if there's a question to all of us, like a group email, then Phil will be the one to answer it. The board chairman will answer it rather than individuals. But I answer most of anything that I see.
Okay. Yeah.
okay. Let's go in here. So Tim and then Gretchen.
Well, I'd like to say from personal experience that OMC is very, very important to our community. It was very important to me. Dr. Sandra Tatro is one of the finest surgeons I know because she spent 4 hours removing my gallbladder.
Wow.
And she said it was gangrenous.
Oh my goodness.
Yeah.
And you're still here.
And you're here.
She's outstanding. And I can say I had, in my
agree.
stay in the hospital, I met many wonderful physicians and staff. Outstanding. And to lose this would be a total disaster for
Oh,
Even
for us and for
Agreed.
Clallam County. And I
Agreed.
think that you two speakers, you're here because you want to keep the
Yeah.
hospital open and keep it functioning.
Also-
So my question is, what was my question?
One of the changes.
I was thinking something the speech I was gonna give. Oh, yes. It seems to me that the changes, possible changes that we're considering, including critical access hospital, could mean cutbacks in services provided, and termination or whatever. And I would be interested to hear you comment on this issue of preserving preserving services that are now provided, like pediatrics and so on. But
My own thought at this point is more and more of our services are outpatient. And that's clinics for primary care, pediatrics, as well as the walk-in clinic and surgeries. Birthing center is almost outpatient. Yeah. And I am not sure we would have to cut back a lot. And that's, I'm sure, part of what's going to be coming out of this study is all those impacts. So that the commissioners can make an informed decision. Yeah.
And also with the affiliation with UW, maybe bringing more services in, again, outpatient kind of things,
And
telemedicine, virtual visits, all of those kinds of things, but utilizing an affiliation with UW to provide stuff like, rheumatology, endocrinology, nephrology, those kinds of things but that's not going to increase the number of inpatient beds. That's people in the hospital. This is all outpatient stuff.
Well, for instance, I think they've already started using telemedicine for stroke.
Yes.
In the ER, which is really, I'm so glad to see that, because our statistics for getting people through the stroke protocol, they're kind of abysmal.
Mm-hmm.
And I think with having that expertise available, it's going to help a lot.
A lot, very much so.
Gretchen?
My question is a little more petty. Why is it that an employee gets to sit on the Board of Commission and answer questions at the Board of Commission meeting when he should be a guest speaker? Because I'm tired of listening to him. He is your employee.
Yes.
Why does he have the same, how shall I say it, the same stature during the Board of Commissioner meetings when he is your employee?
Yeah,
So
I have no idea.
Why does he sit there?
Because that's the way we've always done it.
I have an answer for that, but you don't want to hear it. Yeah,
pitchforks and
I'm so sick of hearing his smiley, happy, oh, we're doing so much better, which is, excuse the French, bullshit, that he needs to step off the stage and I'll do your job and fire him if need be. Please God. He is a detriment to your public perception, because most people who attend those meetings give him the same, what would you call it? The same stature, same gravitas as the Board of Commissioners, when in reality, you're his boss.
Right.
So
that's an interesting point. I don't know why but it's always been that way, but I don't know.
And you're still learning all of what you can and can't do.
Right.
Yeah.
it's very, very common in governance boards for that to happen.
We're running out of time, and Nancy will be the final question, and
Okay.
then we'll do a wrap up.
This is more a comment than a question. You asked about low-hanging fruit. The only thing that your slides did not address, Laurie, is the 340B program for discounts for rural hospital drug procurement. This is incredibly important, especially for cancer drugs. We lost that certification last year. We finally now have a new director of pharmacy, Dr. Charlie Ho. He looks like a bright guy. I hope he can get our 340B funding back this year. It's costing us $8 to $12 million a year because we do not have it. So if we could just get that back this year, we might actually break even.
Yeah.
So that's the first low-hanging fruit that I see. The second, in terms of scheduling appointments, I know that my chart has the capability for people to schedule their own appointments, because when I go online just to type in my chart, I see all these other different instances of my chart where you can schedule your own appointments.
Yeah.
Get ours activated. Let us do that. Then you only need schedulers on the phone for people who don't have online access. And that would fill any open slots immediately that are available every single day. And people could just look online and see if they can do that. So that's number 2. Number 3, find out how many contracts we're still paying on that we should not be. I mean, just in the last 2 weeks, our hospital commissioners found out that there's a recruiter. They didn't know that. They also found out we have a lobbyist. They didn't know that either. So there's all kinds of things that are still, and maybe Gregson doesn't know this. There's all kinds of stuff that the old team knew about that the new team knows nothing about. And you really need to have somebody dig through those contracts. I'm thinking of the mobile MRI contract that they instituted in June of 2025 because we were 1,000 MRIs behind. Well, have we caught up? As soon as we're caught up, cancel that contract. It's a 5-year contract that's costing the hospital over $500,000. So cancel it as soon as you're caught up, and don't get behind again. That's just low-hanging fruit that just drives me crazy, because we're leaving money on the table, we're wasting money, and we're not getting money we should have because of stupid mistakes. That's all I have to say.
Okay.
Thank you.
Before we sign off, though, I would just want to tell everyone at home that, and everyone here, this recording will be made available on our website. And I want to thank Laurie Force and Dr. Carleen Bensen for joining us this evening.
Thank you.
Please, Dr. Benson, convey to the board that when it comes time for us to be participatory in this process, please let us know, because we have members who want to do everything we can to support the hospital and maintain services in our community. And with that, I want to thank everyone for coming tonight, and we'll do some quick closing remarks and sign off.
I think we've kind of talked ourselves out.
Well, I would just ask, and I think, and I get that feeling from the group, stay positive. I have heard so many nasty, negative remarks in this community about the hospital. Please, you don't need to lie, but no, we know we've got problems, but we're working on it. We're trying. This has become so consuming of my life, and working my ass off trying to keep this hospital going. Please give us some credit for that, because I had a little fight the other day with a lady at the baseball game. It's like, come on, we're doing the best we can. We're doing the best we can, but I really appreciate the comments tonight and the questions. And you've got my email address. Just make sure you spell my last name correctly.
Yeah, you can click on the email on the webpage, and it'll go right to her.
Yeah.
So.
But I really appreciate, and I really like that idea of, we need to have some kind of a system to evaluate the CEO on a regular basis.
Monthly.
Yeah, I have no idea. I'm not privy to it, so I don't know.
Perfectly legal and according to Roberts.
Yeah.
For a governance board to establish something like that.
Okay, great. Thank you.
The
I'll talk to
chair should
Phil.
make sure that all of you on the board have information.
Yes. Yes.
Well, it goes with the territory. We've got a president that we're not holding accountable.
Exactly.
We want. All those Republican senators are getting pretty pissed off at it.
You can
I
only
do
hope.
think the easy way to get the information to the board is to have presentations, not just those bullet points,
Yeah.
but presentations from the subcommittee to the board at open meeting. And I'm not even sure if it isn't required. I think a reading from about the Open Meetings Act may suggest to me that it should be done.
Mhm.
Does the
So
hospital have a council?
Yes.
Does the council have any input? I mean, that would be a question I would ask the council immediately.
About evaluation of the CEO.
Well, not only that, but, how much transparency is required by the Open Meetings Act? How much transparency is required, as a nonprofit corporation?
Mhm.
And if you're not getting those opinions from your council, I would be one.
Mhm.
And the next hospital meeting is July 15th
in Squim,
in
Squim.
Squim. So check the
Yes.
OMC.
Do we know
It's
where?
olympicmedicalcenter.org.
Yeah.
it's
the
it's
website.
it's in one of the OMC buildings, exactly where, I can't remember. It's on the website.
I would
And with
also
that,
like to say thank you to Dr. Benson for coming out, and I hope
Man,
that you continue to come to all sorts of different groups to get the word out that the public can have some impact.
Yes.
So thank you.
And if the public is wanting information about where we're at with critical access, we can, that's a great question to bring to the board and say, I really I want to be kept up to date. This matters to me.
Yeah. Unfortunately, public comment
Is not answered
is not answered.
directly.
Right.
But I think your comment answered me very well about the possibility that with a partnership with the University of Washington, there could be an expansion of services provided.
Yeah.
I would think so.
Yeah.
Because that's a big
That's-
question that is in people's minds
Yeah.
about the danger of not only of losing the hospital completely,
Right.
but also preserving it, but with huge numbers of services eliminated.
Yeah. No, I think that's, like I say, outpatient. That's the key.
Thank you, everyone.
Thank you, guys.